Hello, I'm Justine Willis Toms. Welcome to the New Dimensions Cafe. Today I'm hosting Dr. Lonny Shavelson, who is a California physician best known as a national leader in medical aid in dying for terminally ill patients. He's a founder and board chair of the Academy of Aid in Dying Medicine and the author of A Chosen Death and Medical Aid in Dying, a guide for patients and their supporters. I'm speaking with Dr. Shavelson by remote connection. Welcome, Dr. Shavelson, to the New Dimensions Cafe.
My pleasure. Thanks for inviting me.
I'm so glad to have you. It's my honor. And I know that you've been grappling with the right to die issues since you were a teenager. So, can you share with us how this early issue came to you and how it really informed where you are today in the work that you're doing?
Well, fundamentally, I was young. I was about 12 years old. My mother was suffering from a severe bowel disease, ulcerative colitis. And she at the time was pretty miserable and also very depressed. I think those two things commonly go together, the severity of the disease and depression. She talked to me about wanting to end her life, starting when I was 12 years old. It was open in our family. She felt she was miserable and suffering severely. And so we had bedside and around the kitchen table conversations about death and dying since I was 12. The result of that is I was pretty comfortable after a while thinking that, well, every family talks about death and dying this way, not knowing that it's a pretty avoided conversation commonly. But I thought all my friends were having similar conversations around their kitchen tables. It made me comfortable about death. It made me comfortable talking about death, and it made me think about it very seriously. My mom didn't die until she was 75. So we did that dance for many, 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 many years. And she wound up having a death in the hospital from other causes. But it really informed my way of thinking about things and openness of discussions. That's really essential.
And that's what you're doing now is with right to die option. These laws are fairly new in the US.
On the scale of things, we have had the laws since 1997. And so that's relatively new in medical care to have something just pop on the scene at one particular date, never been done before. When they passed the law in 1997, and Peter Reagan was the first doctor to ever offer medical aid in dying, which is what we call it. Medical aid in dying is the right of a patient to receive end-of-life care that may include taking medications to die if they are terminally ill and approaching death. And so that just popped on the scene in 1997. And here we are years later in 2026 coming up. And things have changed drastically. We have learned so much since that first case. We have learned how to do better medications. We've learned about routes of administration. Mostly, we've learned about really becoming a part of end-of-life care. This is not just about, oh, we provide you with a prescription for medications to die, and off we go. We really work with patients and counsel them if they're considering aid in dying, which is what we call it, rather than they're taking medications to die or whatever. Up until the moment they take the medications, we say they're considering aid in dying because they can change their mind. They can get better end of life care. So many things can happen. So the whole process is called considering aid in dying. If a patient is considering aid in dying, we stay with them. From the moment they become eligible, because they fit in the law, they have to have two verbal requests, they have to sign a written statement, have two doctors approve it. Once they do that and they're eligible for aid in dying, we all sit back and we watch each person have their unique way of dying, because nobody knows how they're going to die until they get to do it. They only get one shot at it. And, if that's the case, then you can't know how you want to die until you see how your death is evolving. And sure, you can have some ideas, but guess what? Surprises happen along the way. Sometimes things go really well, sometimes things go really badly. And we will be with you during that process, really ascertaining also that you're getting really good medical care, usually through hospice care, which is done at the home, where you get good palliation, palliative medicine treating your symptoms, whether it's pain, nausea, vomiting, depression, whatever it may be, your symptoms can be improved. And we watch you as you go down your pathway to death. And usually within the last couple of weeks, we can tell that that's really approaching, is when patients make serious decisions about whether they want to take medications to hasten that process or not. That's what's called medical aid in dying.
Can you give me an example of what you mean when you say it doesn't go well?
It's different for everybody. So what doesn't go well is if the patient tells me mostly fatigue. And the most common reason that patients finally decide to take medications to die once they're eligible um, is fatigue. When they call me and they say, doc, I'm so tired, and you're telling me there's only maybe a couple of weeks to go. I can't do this. I'm tired. I don't need those last 2 weeks. Now come and help me. That's when I know it's gotten serious. And palliative medicine for pain and the grandchildren being around and all of that probably isn't going to help. And then I have a discussion with the patient to say, okay, let's talk about time and date, place, who's going to be there. And we still keep it as an open possibility, not an end decision until the moment they take the medications in their mouth. It's a consideration. And so, what is too much? Well, the patient tells me that.
You also advocate having a very, very honest conversation about why a person wants to die.
Sure. This is what I call the how you may die conversation. That conversation is sadly rarely had, which is when somebody sits down with a patient and says, look, you're dying. Rather than, oh, you may live on and we hope you'll live on for longer and all that. It's oh, you're dying. I've been with patients with, let's say, a glioblastoma, or brain cancer, or ALS, or breast cancer with metastases to bone, or pancreatic cancer, whatever. I can say to them, here's the way I usually see patients with your illness die. Not always. There are variations. Everybody dances to death in a different way. But here's the general way of how you may die. Tell me what you think about that, and let's talk about that process. For some people, when I tell them, you know what? For this illness, somebody with leukemia once told me that they're really afraid of a painful death and they want to take medications to die. And I had to say, guess what? People with leukemia don't have much pain. So that's taken care of. There's a little bit of aching, and we can treat that very easily. But painful death, you're going to die of fatigue and weakness as you become more anemic or get an infection. So these conversations are really important. We have to be totally honest with patients about how they may die before they can make a decision of how they want to die. And that's really important now that they have the legal right to decide how they want to die or even when they want to die.
The emphasis you have is a robust palliative care.
Yeah. I often say that without good palliative care, medical aid in dying would be unethical. Yeah, I'm pretty strong about that. Um, the reason for that is this. I don't want anybody to hasten their death because they're getting terrible medical care. I don't want anybody to hasten their death because they have something that we could make better, but they haven't had the chance for that. And so palliative care, which is what hospice does generally, and so that about 95% of all patients who complete medical aid in dying are simultaneously receiving hospice care. They run together. It's not as many people think is that you can either have hospice care or medical aid in dying. We do it together. What that means is that if you're having pain, I'm going to treat your pain and then say, well, your pain is better. Maybe you're still so tired and you still want medical aid in dying, but I'm going to do everything I can to palliate your symptoms along with the hospice staff of social workers and chaplains and music players and everybody who can come to your house and help you out. They have that. And we will work with hospice to really alleviate their symptoms as much as possible. And then you still get to make a decision. Do you want to continue on to what seems like a good hospice death? Or are you still either so uncomfortable or existentially suffering or whatever it may be that you still want medical aid in dying? All that's fine. One answer isn't better than the other. Medical aid in dying is not because palliative care failed. It's because the patient still wants it.
I think they need two physicians to participate.
Yeah. The first thing to do is to work with your existing clinicians and ask them if they know about it and they participate and they understand it. Depending on who they are, they might say, we don't know much about that. In that case, we highly recommend that you get in touch with the Academy of Aid and Dying Medicine at aadm.org. We have a patient referral system where you can tell us where you are, what your symptoms are. We have a fairly extensive intake form you have to fill out, or someone can fill out for you. And we will refer you to clinicians who participate in medical aid and dying, who are quite skilled because they're affiliated with the Academy.
And what are the medications that are prescribed? How have they been developed, and do they actually do the job?
Yes, they are, and they do the job. The first thing about that is, let me dispel a few myths. It is not a pill. Everybody wants the death pill, and it's not a pill. It's 2 ounces of fairly foul-tasting liquid. We can't improve the taste of it because of the ingredients. Then the medications have been developed since 1997. They have evolved through about 8 different formulas. We have gathered, as the Academy, we're the leading institution that gathers all the data about the medications and how they work. So we get to improve them. When we see that something is becoming problematic, we fix it. And so the most common prescription right now that is called DDM-APH has 5 ingredients. They're a combination of sedatives that rapidly put people to sleep after they swallow the 2 ounces of liquid. They go to sleep within 3 to 5 minutes. They're in a deeply unconscious state within about 10 minutes. And then time to death varies. About 85% of people die within 5 hours, and about 1% go on to about 24 hours. That's quite rare. But there's a variation of how people die. We have a set of predictable risk factors so that we can talk to patients about how likely it is their death will be longer or not. But they are not uncomfortable. It doesn't matter if they have a 5-hour death or a 2-hour death. It's the family around the bedside, or the loved ones, or the friends, or whoever is there. Those people are usually having a reasonably interesting, I will call it, time, telling stories, talking about the patient, sharing stories, crying together. It's a death. It's not this wonderful thing where a white bird flies out the window and everything is perfect. Because guess what? The word perfect doesn't apply to death. As well as we do it, someone dies. And that's a terrible tragedy, usually for all the people remaining. But it's the death. We can offer a death that is what the patient wants. It's not better or worse. It's a different death. It's what the patient wants. The medications, as you asked, are a combination of medicines that put you to sleep and then other medicines that stop your heart once you're unconscious.
In the book Medical Aid in Dying, and it's a short book, but it is chock full of information. And I think it's so helpful for people to know what to expect ahead of time.
Yeah, first of all, we highly recommend that somebody who has experience in medical aid and dying is at the bedside with the family. The reason for that is multiple. First of all, if nobody's there, the family has to mix the medications. It's a little bit frightening to do that. You have powders, you have to mix them up to 2 ounces. But more than anything else, is that it takes you away from your role as a loved one to be with the person fully cognizant of your relationship with the person who's about to die. And you don't want to be distracted by mixing medications. And you don't want to be distracted, I think, by even, oh my God, he's turning purple, or oh my God, he took a deep breath and we thought he was dead and now he's taking a deep breath. Somebody who can say, you know what, that's a normal coloration of medical aid and dying. It means that oxygen is decreasing. Or you know what, taking that last final deep breath, that's also normal. Somebody who can normalize the process so the family isn't scared. We don't want people frightened by doing this. We want them to have an experience that their loved one wanted them to have. So we highly recommend, whether it's a death doula, an end-of-life doula who's trained in aid and dying care, or whether it's the physician who was the prescriber or the nurse practitioner, or whether it was the hospice nurse, social worker, chaplain. We have, especially in New Mexico, we tend to have large family crowds, and they include dogs usually, and sometimes a goat or two. So, it's very interesting to watch all the variations that we see, but we highly recommend that families don't do this alone.
Well said. And there's so much more that we could be talking about. So I suggest that people find the book, Medical Aid in Dying, a guide for patients and their supporters, or your other book, A Chosen Death, both of them. And if people want to know more about this work of the Academy of Aid in Dying Medicine, they can go to the website aadm.org. That's aadm.org. Or you can get there through the New Dimensions website, newdimensions.org, where you'll find over 2,000 programs in its archive. I want to thank you for being with us, Dr. Shavelson. I'm Justine Willis-Toms, and thank you as listeners for joining us at the New Dimensions Cafe, and I invite you, please do join us again.